Good evening, everyone. We'll start the hand session, and we'll start the first talk with Dr. Alam. She's a consultant risk surgeon in the Institute de Lama, Paris. I welcome Dr. Alam for the presentation.
Hi, good afternoon. Thank you. Do you hear me well?
Yes, we can hear you, Alam.
Thank you. So thank you for the invitation. I'm honored to join this orthopedic summit once again. So I'm just going to share my screen. I hope you can see my screen.
No, yes, we can see the screen.
Perfect. So thank you. I am Alam Arnaout, one of the hand surgeons in the International Risk Center in Paris, in the Institut Lama. And I will be talking about the Tfcc foveal repair, mainly the challenges, because it is, for me, one of the challenges of the repair of the Tfcc. So to start, just some anatomical concept. We know that the Tfcc was first described by Nakamura as a three-dimensional structure with three main structures. The distal structures, the distal hamate structure, and the ulnar collateral ligament here. And we have the main structure, the proximal triangular ligament, more deeply. From a functional perspective, we know that the distal component, the DTFCC, has a main role of suspending the ulnar carpus, while the proximal component, the deep component, the PTFCC, the palmar and the dorsal radial ulnar ligaments, provide the stabilization of the distal radius ulnar joint, the DRUJ. From an arthroscopic perspective, here is the well-known iceberg concept of Andrea Zei, who described the TFC as two compounds with two parts. The emerged part that we can see on the left, it is a reduced part of the TFCC. We can visualize this part only with a radiocarpal arthroscopy, and it plays a role of shock absorber. And we have the submerged part, which we can visualize only with the DRUJ arthroscopy. It's the foveal insertions of the TFC, and they have a main role of DRUJ and ulnar carpus stabilization. So we classify the TFCC tears according to the Iwasaki classification mainly now. This classification was modified in 2011, and we have first the class 1, the distal tears, and these tears require only capsuloligamentus sutures. And we have the class 2 and the class 3, which involve the foveal insertion of the TFCC. To indicate the repair of the class 2 and the class 3, a healthy DRUJ cartilage is a sine qua non condition. The wrist deformity, the DRUJ arthritis, and of course the irreparable TFCC are contraindication to foveal repair. So for the class 1, the distal tears, the radiocarpal exploration makes the diagnosis, and we use the loss of the trampoline effect, and a positive TFCC pulling test makes the diagnosis and indicate the repair. So we can also probe the DRUJ from the radiocarpal joint here, and we can see here the exploration from the DRUJ, and we can see the detached ligaments. For the distal tears, we use simple suture, capsuloligamentus suture, as here is the principle. It's very easy. These techniques are very easy. We only use 2 portals. The scope is in the 3-4 portal, and we pass 2 sutures with a loop. And outside of the joint, a loop is passed into the second suture is passed, into the loop. And after we retract, we pull down the loop from the RUD portal, and we can catch a simple suture here inside the joint. And we can see here the suture for the peripheral suture. So these techniques are very easy, and I would say the challenges are the repair of the foveal tears because they are responsible of the RUJ instability. We made the diagnosis with the clinical assessment, a positive ulnar foveal sign associated with a positive DRUJ development test has a very good sensitivity and specificity for foveal tears when it is mild to moderate with no response to conservative treatment, or when we have a severe instability in the first place, it is an indication for foveal tear reinsertion. Of course, we can use MRI arthrography, or arthro-CT scan, but the false negative are quite frequent in some situations. And the arthroscopic findings are the most important because they confirm the diagnosis, either with a direct view of the foveal disruption we have here on the right, the empty foveal sign using the DRUJ portal with a scope in the DRUJ, as we can see here, or we can use the hook test only. According to Andrea Zei, he described the hook test as sufficient to diagnose the foveal tears with a very good specificity and sensitivity. So for the foveal tears repair, we have two main families of ligament to bone refixation, the transverse reinsertion. This technique were inspired from the knee surgery mainly in the first place, and the bony reinsertion using anchors. I'm going to talk mainly about bony reinsertion using anchors because it is a technique we use here, and I don't have enough time to develop the two techniques. So for the techniques using anchors, we have three main families of techniques. The outside-in techniques that are mainly used, the first that were described, with the suture path from outside to inside through the two bands of the deep Tfcc. We have the inside-out technique with a very few number of publications. And we have also the all arthroscopic techniques which are technically demanding. So the principles of the outside-in technique, as described by Zei in 2008, he described the technique using 4-strand anchors, and the sutures have passed through the Tfcc from proximal to distal, and we can see here the suture, the reinsertion is secured on the volar and the dorsal side. Now, for the technical points, the exploration is very important because it makes a diagnosis. As I told you before, the scope is in the 3-4 portal, the probe in the 6R portal, and a positive hook test is sufficient to indicate the foveal reinsertion. The next step is creating the DRUJ portal. And use the scope in the 3-4 portal here. And we try to localize the area of the DRUJ portal. And we can see here that we can easily lift up the Tfcc thanks or because of the foveal tears. So here is the creation of the DRUJ portal using a mosquito. And the next step is a medial incision, because it is in this area that we will later insert the anchor. So the scope is in the 3-4 portal. Using a first needle, we localize the 6U portal here. And 1 centimeter proximal, we localize the direct foveal portal. And finally, we perform an incision between the two portals. It is a medial incision. So there is a very important point while creating the direct foveal portal. It is to identify and protect the dorsal branch of the ulnar nerve. And it is very important to put the wrist in some supination. Because you can see here, in supination, the ECU and the dorsal branch move dorsally, and the nerve is protected. So once again, we need to avoid, during creating this medial incision, the pronation, and supination is very important. So the next step is the aspiration and debridement of the distal radius ulnar joint. We have the scope in the DRUJ portal. We have a direct visualization of the foveal disruption area, as you can see on the right. We use a shaver or curate to debride this area. The next step is the insertion of the anchor. We can see here the insertion of the anchor under direct visualization, and we can see the sutures of the anchors that are retrieved from the direct foveal portal. The next step is the Tfcc suture. We use two hypodermic needles that were passed through the TFC. One needle is passed dorsally and one needle is passed volarly. So each suture is retrieved from the 6U portal, as we can see here. We will have a video later. It will be clear. So each suture is passed into its own loops here. And finally, we perform a traction on each suture on the left. And on the right, we can see the reinsertion, which is secured on the dorsal and the volar side. Here is the principle of the suture. We remove the wrist from the traction, we tie the knot outside of the joint, and we can see here the two bands of the TFC that are reinserted with a negative hook test on the right at the end of the procedure. We have a modified technique without using the DRUG portal, since we know that the hook test is sufficient to indicate the surgery and to diagnose the foveal disinsertion. We use only the 3-4 portal, and we debride just using the 3-4 portal and the medial incision, the foveal area, and the next steps are the same. So here is a short video for the main steps. Live surgery we did with Christophe Matulin last year in Coimbatore. And the first step is the exploration with a positive hook test, as you can see here. We localize the 6U portal with a needle. You can see here the insertion of the 6U portal. The next step is localizing the direct foveal portal here with the second needle. And the next step is the medial incision between the 6U and the direct foveal portal. We perform the medial incision. Next step is the debridement and of the foveal area here. Through the medial incision, we can see how we can lift up the TFC on the arthroscopic view. The next step is the insertion of the anchors. You can see the direction of the anchors from distal to proximal. The two sutures retrieved from the direct foveal portal, as we can see here. Next step is to pass the two sutures, one dorsally and one volarly. You can see here the principal and the volar suture pass through the TFC. We retrieve each suture from the 6U portal. It's very important here. I hope you see clearly my screen. We pass the suture into its own loop. And finally, we tract on the sutures and we can secure. On the left, you can see how we tract on the suture, and you can see on the right the arthroscopic view, and we secure the two sutures here. And we tie finally the knot in the wrist in slight extension. So we have also the inside-out technique. We have a very few number of cases and studies that were published. It is very seducing because we can grasp the TFC directly under direct visualization, and we can use the standard portals. We have also the all arthroscopic techniques. The Adzei technique is quite similar to the technique we've just seen before with the medial incision. The only thing it's technically demanding to create the 6U and the direct foveal portal. So we need to have some skills in wrist arthroscopy to use this technique because it's dangerous for the nerve. We have also the Fontes technique, which is an all arthroscopic technique using a mini push lock with a distal 6R portal, accessory portal. And the aim is to facilitate the ligament bone healing using this technique. And we have the Getzler technique, which aim is to limit outside in technique complications. It avoids incision over the ECU and it doesn't require any suture notes. But the Getzler technique is technically demanding. We have about 14 steps in this technique and it is hardly reproducible. So now if we talk about the pro and con of each techniques, the outside in, the inside out, and all arthroscopic technique, we can consider that the outside in technique are secured and easy. That is the technique we use in our center because they have satisfactory follow-up. But on the other side, they require minimal invasive approach. We can have some problem of dorsal branch of the ulnar nerve neurocratia, some cases of subcutaneous irritation on the node, and it requires the opening of the ECU shed. For the inside-out technique, it's a seducing technique, as I told you before, because there is a direct grasping of the TFC. The floppy disk is easily located. There is no opening of the ECU shed. We use only the standard arthroscopic portals, and we use a mini open approach to create the direct foveal portal. But we have only one study, and the level of evidence is very low for the amendment for the inside-out technique. And finally, for the all arthroscopic techniques that are seducing, no opening of the ECU shed, there is a theoretical decreased risk of dorsal branch of ulnar nerve lesions because there is no creation of direct foveal portal and no subcutaneous node. But as we've seen, these techniques are either technically demanding, the Getzler one, they require expensive device for the Getzler, and for the Fontes Kermarek technique, more follow-up is needed. And thank you for the attention, and I am ready for any question. Thank you.
Thank you, Alam. That was a fantastic presentation. Is there any questions for Dr. Alam? Alam, I have one question.
Yes.
Like, do you do the wrist MR arthrogram for all cases, or do you do that for only selected cases?
Actually, thank you for the question. We have the possibility here in Paris to ask for any exam. So we ask for normal X-rays, plan X-rays, and for MRI, because good quality MRI helps for the diagnosis. And the arthro CT scan, for example, is very painful. We have some cases of false negative in the chronic cases. So I would say for us here, because we can do it, and for medical legal issues, we ask for X-rays and MRI, and it is the diagnosis, the arthroscopy and the specific test with the clinical assessment with the DRG development, etc., that make the diagnosis.
Thank you, Dr. Alam.
That confirm the diagnosis. That confirm the diagnosis because, for example, if you have a mid instability, it happens. If you have a mid clinical instability, and sometimes we put the arthroscope, we don't find foveal disinsertion. We find a large peripheral disinsertion. And in these cases, there is no consensus. There is no real need to do a foveal reinsertion with bone anchors or transverse suture. We can perform a double loop suture. Just suture is sufficient. So the arthroscopic assessment is the most important for the diagnosis and the clinical assessment, I think.
Thank you, Dr. Alam. Thank you so much. We'll move to the next speaker.
Thank you for inviting me, and Have a nice session. Thank you.
Thank you. We'll call upon Dr. Vigneshwaran. Vigneshwaran is a consultant in hand surgery in Ganga Hospital, Coimbatore. Dr. Vigneshwaran will be talking on scaphoid non-union principles.
Good evening, everyone. It would be intriguing for an orthopedic hand surgeon with the options and evidence available for treating scaphoid non-union. However, you should be aware of the fact that these procedures worked in the hands of the authors at their place with their patients. Myself, Dr. Vignesh Ran from Ganga Hospital, would be presenting on principles of managing the scaphoid non-union based on the evidence available and experience gained over operating 191 cases of scaphoid non-unions in the last 12 years. So what is the scaphoid non-union and when to term a scaphoid fracture as non-union? Any fracture of the scaphoid which is unhealed beyond 6 months should be considered as scaphoid non-union. However, we should always remember that adequately treated scaphoid fractures without showing signs of healing beyond 3 months can also be treated as scaphoid non-union. So why the scaphoid goes for non-union? First thing is a complex three-dimensional anatomy of the scaphoid. It is difficult to image, difficult to interpret the imaging findings, and difficult to fix. As we all know, poor vascularity, the safe rescue answer for all the trainees in hand surgery when they are asked what is the cause for scaphoid non-union in their exams. Beyond poor vascularity, major causes are fracture instability. Any fracture line beyond the apex of the scaphoid lead to volar angulation of the fracture, resulting in a big gap. And the intra-articular nature of the fracture, the